Today on the Anatomy of Therapy, we are talking about knee pain. We are talking about reasons you get knee pain. We are talking about reasons where maybe the knee pain just kind of comes out of nowhere. Why does that happen? Or perhaps you are doing some activity and then maybe there's no trauma and then your knees just kind of start hurting seemingly out of nowhere. Sometimes you have knee pain on one side, sometimes you have knee pain on the other side. Even though you're taking the same amount of steps and doing seemingly the same thing on either leg, why do you get knee pain on one side only? Why does it hurt on the outside? Why does it hurt on the inside? We're going to start to answer some of these questions, hopefully describe what is going on with knee pain. And at the very end, we're going to give you some solutions on how to deal with your knee pain yourself. We're going to give you a challenge for the week. If you can do it, I think it'll knock out a bunch of your knee pain. But first, why do you get knee pain? Here on the Anatomy of Therapy. Welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Bobby Riley. What's up, Bobby? What do you know about knee pain, man?
We're gonna find out, I guess. We're gonna find out. We're gonna find out.
So like, what are common reasons people have knee pain? Like, when patients come into me, I hear a lot of patients. I mean, 80+%. It's insidious. It comes out of nowhere. They don't know why it started. My knee just started hurting. There wasn't like they weren't in a car accident or something like that. A lot of pain. Let's just say people will say it hurts. My knees will hurt when I go upstairs, or I sit too long. Then after I sit, I get up and my knee starts to hurt. Or if I stand too long, if I'm standing still too long, that's a big one for me for some reason. Those are probably the less active. What are the reasons you commonly hear?
Well, then you have the kind of more the athletic population, right? That says things like my knee starts to hurt around mile 9 when I run, or my knee hurts in the bottom of a squat, or in the bottom when I catch the clean in CrossFit.
Right.
Or they'll say it hurts the next day after hard training. So, maybe they get through their training, but then they wake up and then everything feels really sore in the knee. Or maybe they get some sharp pains for 2 or 3 days and then it kind of fades away. And then the cycle kind of just keeps going and they don't know where that cycle comes from. I think it's quite common, right? Like a lot of people can get through something and then they pay for it. And they're kind of like, they have to quit that activity, they feel like, because they can't tolerate it, even though they didn't get immediate feedback. But that's more from the active population that I see those. But I mean, both too. I mean, those same people can still have the same issues that you were first saying.
Yeah, for sure. I mean, and then so people get knee pain, and one of the other things with knee pain is that it's not always there. It's one of those things that's there, like at the end of the descriptions we're talking about, at the end of the little story, all of a sudden knee pain just kind of pops up, and maybe in the beginning it comes out of nowhere, and you're like, well, I didn't do anything specifically to my knee, and it just popped up. But then after a while, we have patterns that will habituate and things we get familiar with doing, like especially when you're talking about those big movements like squatting and what you were talking about snatching before we had started recording. And some of those movements need to be so habitual that you don't really think about snatching when you snatch. Like you shouldn't be thinking about the mechanics of your squat as you're squatting. Mostly, you just kind of need to start squatting, break a sweat, get some work done. But the same thing happens when people are walking. Like, after a while, they just kind of know, oh, shoot, if I'm up on my feet for an hour, things are going to start happening to my knee. So I need to start preparing and planning what to do to not deal with that. But knee pain also seems to be one of those things that people put off. Maybe, I don't know, maybe it's post-COVID and, I know people had some problems and they were tentative about going into the doctor's office to see, doctors. And I can appreciate that for sure. But knee pain does seem to be something that people just kind of like, it'll get better. And maybe that's because it seems to get better. What's your take on that? The coming and going of
I think I can understand that. I feel like a lot of these, these knee issues that come with time, they are, maybe not as extreme. They don't prevent them from working or walking, but they're just kind of nagging the same way maybe like a low grade heel pain or foot pain would, like I could still do all the things, but so maybe they put it off like that. But I think it's because it's kind of misunderstood too, like in the sense that it's really common that there is no assigned trauma or no real explanation in their mind. You know, all of a sudden they woke up one day and they had knee pain going down the stairs, and it's quite sharp, and they don't really understand that kind of thing, right? So it's not so easy to bring that into a clinician and try to explain it. You're just like, well, maybe this is just going to go away. This is something kind of weird. I mean, I didn't do anything, right? I
Right.
mean, needless to say, like, they don't understand that it takes 30 years for, you know, the cartilage to kind of wear down to where you hit some of these sensitive structures underneath, and then now maybe descending the staircase is no longer good. But the 15-year-olds don't feel that because their non-sensitive cartilage is still fully there, intact.
Right. For
And
sure.
it's not till later, which I think we should touch on the idea that, you know, just real quickly, that the knee is like this hinge joint, right? That we all know. It's got a small amount of rotation as well. It starts to internally rotate the lower leg as you bend it, and it screws home as you straighten it. But for
Right.
the most part, it's just a hinge. And, you know, sometimes I'll tell my patients, like, see my door right there? It just opens and closes. And I anticipate that the hinges on that door will last quite a while. And then I'll say, but imagine if I hung a 10 kilo or 20 kilo or 20-pound weight from the door handle.
Mm,
How long do you think the hinges would last then? And
mm,
every single patient would be like, well, yeah, much, much, much shorter. I'm like, yeah, because now you just inserted an element of like torque and shear through the hinges because of this weight that is basically diametrically opposed to the long lasting structure of a hinge.
for sure.
And that's what happens with knees most of the time,
Mm,
is there's some kind of low level compensation that starts to create torque. Now there are genetic ones too, you know, these you know, maybe you were sat in the womb a certain way and your tibia is a little bit curved, and we have all sorts of weird genetic things that predispose our knees. And sure, maybe your knees are going to wear out no matter what you do sooner than another person's, but most of them come from, you know, through life experiences where we get these adaptations and compensations, and feet start to flatten and hips start to turn out because you lose internal rotation, and but your foot's still got to walk forward, so you start to twist your knee. That's the weight hanging on the door handle, and now the hinge is starting to wear out. It doesn't wear out right away, but
right.
one day the door just starts to squeak. Like,
Right.
you
For
don't know what
sure.
day it's going to be, and it's not going to be that anybody like hurt the door the day before, but just one day it just starts to not do so good, and then the door doesn't quite close right because it's hanging now, and now you have, you know, time to replace the door. And
Right.
that's where you have to replace the knee, is because you cause so much structural issues from these compensations over time, which
Yeah.
is the main thing that should be going off in your head, is like, fix these things early or work on these things right away. Because I can tell you, if you needed to address some kind of compensation when you're young, it's super easy. But when the feet are flat and the hip doesn't turn in anymore and the tibia is counter rotated, and that stuff's hard to, you know, we get these Instagram messages like, how do you fix knocked knees, and how do you fix, man, I don't know.
Good
Maybe if you,
luck.
even if you lived with me, I'm not sure I could solve that problem.
Yeah.
So yeah.
No, I think that's a great picture of like what's going on in the knee. I mean, I think some of the in terms of that hinge metaphor image you're talking about, I mean, one of the compensations that kind of happen from that knee that I see a bunch is patients will hyperextend their knees. They'll lock their knees all the way back
Mm.
when they're standing still. So they'll overextend their knees. And so what I see is that, I mean, we've lost certain other ranges of motion, because they're not used or ill used or not used appropriately. Just, you know, we sit too long, we don't exercise, whatever it might be. And so one of the main things that happens is that the knees will lock backwards. In other words, instead of bending forwards, they go back. And when you're talking about the knee being a hinge joint, it is trapped between the hip and it is trapped between the ankle. And so a lot of times with patients, Shante Cofield made this analogy up. We've used it plenty of times here. I'll tell the patient, I'm a firefighter and an arson detective, right? So we need to put out the fire in your knee. We need to do things to your knee to give it some relief. However, long term, we got to figure out why that happened, right? And that's unique with some of the examples that we've been given, what's been going on before, and a good history. Hopefully you can see a good clinician. They can kind of suss out your medical history and hopefully uncover some of those things. Or perhaps you can do that, like what are some of the recurrent patterns that you find yourself in? Can you get ahead of it? Can you stop it? Can you change it? I think you can. But so what I'm talking about with the knee kind of going backwards and hyperextending, and that the knee is the ultimate midjoint and is trapped between the hip and the ankle, the two things, and we'll kind of get to the challenge towards the end with this and why this will help, is the hip above and the ankle below. So the hip above commonly lacks hip extension. And so if the hip does not extend, any number of things can happen. Your low back can extend. We've got plenty of posts on that, but your knee can hyperextend because you lack proper hip extension. You lack a posterior hip capsule. Your hip flexors are too tight, which often happens when we're sitting too long. If you live in Western civilization, welcome to hip flexion. Hips don't extend well, so your knee will try to extend. And I think that's one of the reasons why people get anterior knee pain. There's anterior knee pain, but there's also medial and lateral knee pain, right? I would say the anterior one is a bit more common, perhaps starts there, maybe spreads left and right. So the hip not extending is a big one, and we'll hopefully give you some solutions for that towards the end. But then also the ankle. The ankle doesn't dorsiflex. It doesn't go forward because it gets trapped. Feet fall in, you get flat feet. And then, so the knee has to take over for what the hip and or the ankle is not doing. So these are two other things that maybe you don't even have problems that year. Maybe you don't feel that you have pain at your hip or pain at your ankle. This is perfect. That means these are windows into making a change in your body. And so people go, patients often, my hip doesn't hurt. I'm like, great. This is where we can affect more change, because your knee hurts. You can't really move your knee without causing it pain. So there is going to be a poor adaptation if you're like fighting through the pain to do your rehab, do your stretches, do your exercises. If your hip isn't hurting, if your ankle isn't hurting, these are ways that we can get some motion, get some lotion into your knee. And we're already kind of talking about some of these examples. Like if they're coming in or they're listening to us, they know that they need some help. But I feel like a lot of patients have how they think their knee is going to be fixed, like their solutions. Like what are some common solutions in terms of how we fix knees, or how they think they're going to fix knees?
Yeah, I think the one that jumps out at me right away is that, like, I need to stretch that then right, or I need to foam roll that then right, or I should use my gun on that muscle then right. Like,
Theragun.
And Theragun,
Jesus, no.
And like in my mind, I would say, yeah, that's all fine. And you know what, you can, all those tools, like let's say, because sometimes, I've almost gone so far to think that the structure doesn't even matter. It's just the integration of how the organism moves is what's important. But that's not always entirely true, right? Because we have to desensitize tissue, or we need to still allow work to get done. And we can do that if we can allow some movement to occur we're in a safe way, right? So passive stuff like foam rollers, people's hands, stretching, passive stretching, Theraguns, metal scraping tools. Like you can think of that, those things are a method to allow you to increase active things. So those passive things allow you to increase active modalities. And active modalities actually allow you to change tissue. So let's say, we want to increase the structural, the cellular tissue of the knee. We'll just be general here. So we want, like, let's say the tendons and then the fascia. We want to allow more resilience in this tissue. But so we can do like a slant board squat where your toes are down and your heels are very elevated, takes your ankles out and you squat deeply and you load the knee a lot. Knees go way over the toes, which allow not as much as actually a flat ground squat, but that's beside the point. But it allows you to load the knee quite a lot, which those tissues feel, and they respond to stress the same way your fingers respond to playing the guitar, and they hurt like crazy for 5-10 days, 2 weeks, and then they start to thicken and it's fine. But what if you can't go down into that squat because of the pain? So maybe you can foam roll your medial quad or your inner quad, your VMO. You can foam roll it, you can scrape it, you can do some PNF stretching, some static stretching, whatever you want. You can use voodoo floss from Starrett, and all of a sudden the knee get some freedom, and now you can slant board squat pain free. You don't wake up the next morning in pain, and now you can get cellular, like I say, load mechanotransductions, the fancy word, but we can get stress through those tissues and allow them to build, right?
Yeah, no, like the positive stress into the tissues. And there's this one thing we've said before, but there's pain and there's pain. So a lot of the things that Bobby's talking about can be a little bit painful or sore, right? And so you want to create a situation where your body can reorganize, because if you're stuck in a painful state, your body's constantly trying to reorganize itself. That's what pain kind of is. That's a painful response. And if you're stuck in that painful response, your body is having problems reorganizing itself. There's a bit of chaos and there's a lack of order. So one of the things you can do to disrupt some of that disorganization, I guess, is to cause a little chaos with, like we said, the voodoo, the floss band, the foam rolling, right? So passive things, or the scraping materials, the Theraguns, right, around that knee. And that will start to force your body to have to start to reorganize. And once that process starts, then we start to mold it, right? So, I mean, I don't think we've ever talked about this one, but like when a potter is making his clay, like you get this clay and it's really hard to mold at first. You have to add some water. You have to get this thing spinning. There are outside stresses, and then you have to stress it accordingly, right? So once you get the clay warmed up, as it were, with these passive tools, you might get some relief. You have to be careful of getting this relief, because this is kind of a false window into you getting relief. And then you're just like, well, now I got a Theragun every day. No, that opens the door to you then being allowed to mold and shape the knee, the structures of the knee, the soft tissues of the knee, the bones, the muscles, the tendons, the menisci, the meniscuses, to shape and reform in a way that is more conducive to your life. And this is what we're talking about with squats, being able to load the knee thoroughly and evenly. One of the things I also like with the slant board squat is great, or elevating your heels is great. Goblet squats are an epic way. Or if you don't have a weight to hold a goblet squat, you're holding the weight in front of your chest. Or if you don't, you can even start with like holding a door, holding two handles of a door, and then using that to kind of squat down and back. And so there's this thing also where, if you let your knees go over the toes, you put more stress into the knee. If the knees go further back behind the toes, you put less stress into the knee. So we've got some of these messages as well about, we had a stretch a week or two ago where I did one and Bobby did one, where basically like leaning the knee well over the toe. It was kind of more of a groin stretch and a hip opener. And so more of the stress was in the hip, but secondarily, of course, you're going to get some stress in the knee. The knee can go over the toe. Your knee can't. It should be able to go. So we want to, the further that your knee can go over the toe in a pain-free way, the more healthy the joint is. And there's this saying, we've said it many times before, end range health of a joint. If you are strong at an end range, if you can get to an end range, that tells me that your joint is healthy. So the goal would be to get your knee well over the toe in a healthy way. So that might have to progressively and slowly happen. But if you can do that, that's a good sign, because you need to know there's not a metric. You can't take your blood pressure for your knee every day and be like, it's a little bit high, it's a little bit low today. Sometimes it's hard for people to really know what the heck is going on with their knee. And so testing your knee over the toe, those stretches we were talking about, with your foot on the ground, or Bobby did a great one with the foot well elevated, which should also take some stress off the knee if your foot is elevated, to be quite honest. It'll force more stress in the hip and the groin. Is a good test to see if you can put that knee over the toe, how well you are improving in your knee pain. So yeah, other solutions. Let's get into Yeah.
Well, I would say, just real quickly on that point, though, if you have been avoiding your knee ever crossing your ankle, because like, I don't know, you read somewhere that knees over like past the ankle joint is bad, and you've been doing that like old school Kelly Starrett, like get out of a chair type of move to always stand, like that's probably why your knees are bad. Like, to be honest, like if you never take them past your ankle, or especially past your ankle, but which is kind of impossible if you walk on hills or anything, but or especially and then past the toes, that can explain a lot of dysfunction right there. Because one of the easiest things that we do as clinicians to see your knee health is we lay you on the table on your back and we just push your heel to your butt.
Yeah.
That's it. And and it tells me a lot, actually, because if it just like butter, I could just use one or two fingers and just push their ankle just all the way to their butt. And I've had people tell me, like, I think I'm a candidate for a knee replacement, I've been told. And if I can just softly push their heel to their butt, I'm like, you need a different orthopedic surgeon, because that knee has got great accessory motion. It's free, it's loose. So the first thing is, if you have trepidation just laying on your back and trying to pull your heel to your butt, and then like pressure starts to build, and then structures start to become uncomfortable, almost like it's pinching it could be the back corner, it could be the front corner, it could be just a whole circle of pressure in the knee. Yeah, you don't have like a knee that's free. We'll just say free, so to speak. So that sounds like a person that wouldn't put their knees past their toes. That also sounds like a person who would have knee pain trying to run or to go to CrossFit class, or even just play with their children, or especially do things like lunges. Like, oh my God, I cannot lunge. Every time we post a single leg thing, I get like 10, 20 messages like, yeah, that just causes me knee pain. I can't do anything on a single leg. And that's not normal either. And then you get the people that just say, yeah, the knee shouldn't go forward like that. And then I'm just thinking, I don't know how anybody pooped before like 1850, because like, I don't know if you know this, but we normally just squatted to poop. Like, toilets didn't evolve like we did. They're not a real thing. So you just fall over, or everybody on earth would have hemorrhoids and constipation because they wouldn't be able to go to the bathroom. So you have got to be able to put your knees past your toes. And the hamstring and the calf should be able to just smash together. That's a healthy knee. And you can see these in Asian cultures where they do it all the time, and they're 90 years old and they can sit in a full squat. And I bet the rates of knee problems in those countries are very low. Now, they're not trying to CrossFit. I understand there's a lot of stresses that we add personally by choice on our knees. That's a totally different topic. But if you're just out there going, okay, they're just still saying a lot of like kind of over my head stuff. If you don't have a knee that is just loose and can go into full extension and go into full flexion, or heel to butt and then fully straight without, and if you have some pressure in there, discomfort, that's the first thing to solve, I would say, because it's like you don't want to load a structure that doesn't even have the capacity to bear it through any kind of functional range.
No, you posted a good one this week from Greg Cook, who said move well and then move often. And so, and it's also kind of something you said a couple podcasts ago about the international pilots doing a heel to doing a regular quad stretch. Like, that's not going to be enough. The idea of the quad stretch, where you grab your ankle and you pull your heel to butt, is an initial way to see if you can get that knee flexion. That is a passive way. It's not unlike the instrument assisted stuff, the Theraguns, the lacrosse balls and foam rolls, right? You need to have your foot on the ground, like Bobby's talking about, with people that can squat their butt all the way down to the ground and have pressure on that, all the way flexed and all the way straight, which is why squats are a great thing. Now, one of the other things, and I think we're going to get to our challenge for this week, and I think it's going to be a good, you got another one?
Well, I wanted to just clarify, though, for everybody who quickly checked that and goes, well, that's easy. If you're that person that said that's easy, well, then you need to check what John said earlier, which is above and below. So if that knee just moves beautifully, but you have all this knee pain, it hurts when you run, hurts when you jump, hurts when you go downstairs, well, then you need to check other things. You need to check your hip extension. You need to check your hip rotation ability, check your ankle, check your foot strength. Does your foot collapse like crazy when you try to 4-foot run because you read Chris McDougall's book and you wear sandals like John? and your knee hurts after like 1 mile. Well, okay, so that in that case, the knee is the innocent bystander. It's the kid getting bullied in the playground, and it's not his fault. So I just want to
Yeah.
clarify that that's the
Yeah,
other
yeah.
side of the coin.
No, for sure. I mean, go back and listen to our Nick Askey episode about 100 miles. Like when people do 100-mile races, they don't talk about mileage because the mileage is insane, or mile time. They talk about time on feet. How long can you stay time on feet? How much can your knees take? And I remember Nick in that episode, Dr. Askey was talking about how much stronger he feels just day to day by spending all this time on feet. Like they just run for hours. The mileage is what it is. And he tries to get 3 hours of time on feet, 2 hours of time on feet. That's one of the metrics as well. As a doctor, you come in and you're a patient of mine. How much time on feet can you take? And we got to see if we can increase that, obviously. So time on feet, strain upright in kind of a normal range. When you're really walking around, your knee doesn't move that much. It doesn't flex and extend that much. And so we're talking about these active people that flex all the way down into a deep squat or something like that, or, even going upstairs is not that much extra range of motion on your knee. And so we want to do a slowly increasing capacity of your knee being able to go through range of motion and accept that stress and accept that load.
Yeah, I like you brought up that point about Dr. Askey, that like that TOF, time on feet, because that's the same reason those people, not all of them, but a lot of them are standing with that extreme knee extension. Those people that lock their knees back. It's if you just sit in your gas powered chair to drive to your work chair, to drive your gas powered chair back to your Netflix chair.
Yeah.
When you stand at a really long line, or you go to a concert once a year, like your structures like are not going to tolerate standing, even something as basic as standing. And you like, you can't squat because maybe you don't do that, so it doesn't tolerate that. So what can it do? Well, you can just jam your joints to their end range, so that way your body just stands up by stilt mechanism, which is just locking bones on bones. So you just can stand on your skeletal system and no muscle has to work. and we do this with our low back too. So people ask about anterior pelvic tilt all the time, and like people are doing that often because well, a lot of it is because of weird tensions and stuff, but often it's because of like it's just easier to just lay your bones on themselves, as opposed to have this dynamic muscular system that's just holding the tension of your body up, which is like this word biotensegrity, some fancy term. I think I first heard about it in anatomy trains. But this tension throughout your body, this biotension, like if it's not tuned right, well, yeah, it's just way easier. And then if you're just completely, what do you say, detrained, well then yeah, you're gonna default to these I love, like, the PRI people talked about this, like you default to pinch joints as opposed to load structures, because you cannot tolerate like bearing gravity in the correct way. So
Sure.
yeah, it's a little aside, but
no, it's perfect. I mean, I think ultimately, in terms of what we're talking about with knee pain, patients are looking for certainty. They want to know exactly what is going on with their knee. They don't want to know why their knee is hurting. They want to know how to get out of it. Everybody has a need for certainty. However, I think one of the fixes is actually uncertainty. It's actually variety. You get caught in these patterns, you get familiar with these patterns, and there's nothing more dangerous than familiarity, right? Because it just kind of creeps up on you. You know it too well. Sometimes people become aware of it, and that's good. And hopefully with this podcast, you become aware of some certain things and test them and fix your knee on your own, on yourself. But variety is the key, okay? And slow and adaptive variety, right? Expanding and trying new things in a safe way will slowly allow you to expand and allow your knee to take more and more stress. How can we get our knee to build more variety?
no, again, usually I feel like you're just teeing me up for this whole episode, because like that's really good, because we also just do the things we like to do, right?
Yeah.
Like all these people with shoulder pain that just love to bench press 4 times a week. It's like, okay, I mean, I love the bench press too, but I mean, there's got to be a point at which you go, okay, there's just not really a return on my investment of time besides my bench number, which nobody cares about besides you, unless you're the world champion. So unless you're, yeah, if you're really strong, people care, but otherwise they don't.
No.
So like, so you have to ask, like, so what happens is somebody will do, let's just say, a back squat, And then they try to front squat. That doesn't feel good. So they just don't front squat. Or they try a Cossack squat, which John will explain here in a minute. And they can't do it, or it hurts. So they're never going to do that, as opposed to leaning into the discomfort, which might be what you want to do. And I don't mean discomfort like, oh, that's shooting pain. Don't lean into that pain. But you should lean into the discomfort of like, okay, I watched Dr. John on this Instagram put his knee and shin against the wall and do a wall stretch. And I can't even begin to get into that position. Well, then you should just real quickly Google like progressions on wall stretching, because if he can do it and he's just casually doing it, and yes, John has some skills compared to the average person, but he's also not some elite Olympic gymnast either. So
No,
the point
I'm
is like, yes, he's definitely above average for these things. You don't always have to accomplish our goals, but if you're just terrible at something, that's a good time to say, I should probably lean into this, right? So if you can't bring your shoulder over your head, it's not, let's max out on thrusters today. It's, I should figure out how I can get my arm to go naturally overhead better. And then you know what'll happen? Your thruster max will go up. You don't even have to worry about trying to increase your thruster max, because you'll just get better movement, and therefore the force will go where it's supposed to go. Now it'll go into the bar if you're an athlete, for example.
for
So
sure. No, I totally agree. I mean, in a lot of these, hopefully we are exposing you to some of your limits, the edges of what you can do, because at the edges of what you can do, you find that you can do more. And so again, we want to approach these limits cautiously and easily. When people smash through limits, that's when injuries usually happen, right? That's where pain usually starts. When we randomly smash into our limits and we didn't know, that's where we get surprising pain. So going through these stretches or exercise is really just trying to approach your limits thoughtfully, and then pushing them just a little bit further north, a little bit further south, a little bit further east, right? Going a little bit further each time, and then playing the long game. We've talked about this many times. You need variety, but you need a little bit of consistency in that variety such that it both kind of expand. And the way that we want to test you this time, I think, and we'll make some videos on this week just so you guys can see. Maybe we've already made it since by the time that this thing is out, but the Cossack squat. Actually, I would highly recommend, Marcus Philly has like a 25-minute video on YouTube, Filly. Yeah. Great CrossFitter, fantastic follow on Instagram, puts out tons of free content. The guy is a workhorse, both physically and mentally. He's great, but he has a 25-minute YouTube video on all the variations and progressions and ways to do a Cossack squat. A Cossack squat, if you're thinking about it, just if you haven't seen it, it's your feet much wider than your shoulders. And then you shift your weight to one side. So you shift over to the left, and then you bend your knee and try to basically do a one-legged squat down into that side as deep as you can. You return up and you go to the other side. There's a bunch of different ways to do it. Sometimes you go low and you can stay low. Sometimes you come all the way up and go to the other side. Sometimes you go to the middle and you do like more of a horse stance. Again, there's a bunch of different ways to do this. And so I would just encourage people to go look at that video, or we'll post some this week, and try to do the Cossack squat. Now, how is the Cossack squat going to benefit our knees?
well, just before I answer that, people who see the Cossack squat online say I can't do that. Like, it definitely got downvoted in our online voting recently. It's infinitely regressible unless you need a new hip tomorrow, because you can't bring your leg out to the side at all. Like, well, yeah, this is not for you. But if you have an okay hip, like it doesn't need a hip replacement, well, then you can squat 2 inches down. You can have a really high chair that you just touch your butt to and then go up,
right,
like a bar stool, like you're barely squatting. It can be everything from that to touching your butt on the ground. So just realize that. And you can change your width of your stance up too. And you can point your toes out. And when you shift to one side, you can lift the foot off the ground, the toes off the ground, go onto your heel. So just realize that you can make this for you. I secretly recommended this one for this because I think most people's adductors or the groin muscles are quite terrible. We're just we're quite sagittal people. We walk forward, we sit, we cross our legs at our desk. You know, we have forward pelvises a lot. We have a lot of these issues, and we don't really move side to side. You know, we stopped playing basketball in like 1985 and haven't done it again. So the Cossack squat requires like some flexibility in the groin, and the groin muscles pull on the knee, they pull on the hip, they pull on the pelvis, they can pull on your low back, they can do all sorts of stuff. And if they're tight, they can cause hips to rotate. For those people who say, I got twisted pelvises and I'm getting it cracked back into place, yeah, probably not. You're more likely try to figure out where these tensions are pulling on that pelvis and fix that. And then if you're doing a full Cossack squat, it demands full ankle mobility, full knee mobility, full hip mobility. It demands a mobile pelvis. It demands a spine that can actually completely segment and open. If you're doing let's say like a weighted butt to ground Cossack squat, and you need all of that. You need middle back flexibility. You need to be able to breathe. It's just fantastic one. And at first, yeah, you're not going to maybe be challenging all those things, but the better you get at it, the more structures you challenge. And like I said, I secretly like it for the groin because I think it's one of those things that pull on our femurs and pull on our tibias and cause this torque at the knee. And so all those people that have this kneecap pain, you know, a lot of times the kneecap's not the problem. You know, you do this McConnell taping or like pull the kneecap over and stuff.
Right.
It's like, but it's probably the femur underneath it that's the problem. Like the kneecap's a sesamoid bone. It just floats there. So it's the structures underneath of it are getting pulled around and causing this kind of rubbing underneath your kneecap, tearing up your cartilage and giving you these diagnoses that your doctor's giving you. And this is totally off the topic, and I want John to go back to the Cossack squat, but my like elevator speech for this episode would be like, if you go to your doctor and they give you a picture, an x-ray or an MRI, like you guys send us on your DMs and say, what do I do now? And you send us a picture of your MRI or your x-ray. You immediately know more than those people by just self-assessing your own body. Like lay on your back and pull your heel to your butt. Can you do it? Can you do a squat? Because you immediately have a direction to go if you can't. Versus that x-ray tells you nothing except for there's some structural changes maybe, you know, unless you have a gigantic bucket handle tear of your meniscus and it's like locking your knee into place and you can't move your knee, or you know, it's like catching. Then you need the surgery for that. You need to go see that doctor. But most of the time, what do they just like touch it? They like poke it with their finger and they're like, hurts right here, right? Okay, let's do an image. And it shows up, you have some degeneration and you have some damage. And it's like, okay, that tells you nothing. It doesn't, everybody has some level of issues. So if it's not traumatic damage on these things, just start self-assessing. Try the stuff we do, see what it tells you. If you can't do it at all, maybe there's a little eye-opening thing to say, hey, I should probably work on something here. And you can start to, you know, the more aware you are, the better. So we'll come back to the Cossack squat, but that was my last little, because we didn't go into like specific knee issues necessarily. But the thing is it kind of doesn't matter if it hurts at it does matter sometimes, trust me. Like, yes, it does matter if it's your patellar tendon versus your meniscus, and one has a lot more ability to heal than the other one. And I know that, but it kind of doesn't matter sometimes, because if you can just find the weakest link, like I wrote down in my notes today, you know your weaknesses. Like, you're like, yeah, I know I can't squat. My right ankle, I broke it when I was like 15 and it sucks now. Okay, well, that's probably why you have some issues. Just start working on those weaknesses. People know their weaknesses. They may not be able to define the muscle or to use big terms like mechanotransduction, because it doesn't matter though. So just, you know, like I can't do that stretch that I always see everybody else do. I can't sit like on the floor like I see my friends do. Like, just work on those things. That's honestly better than any just here's your picture diagnosis. So anyway.
No, that's
done.
great. I mean, you're great. From a clinical standpoint, you are meant to do tests to change the treatment, to find out what the next step is to do. And so when people get tests back, when a doctor gets a blood work back and he says, oh, your white blood cell count is elevated, now we know what the intervention is. So when people get images back, they're just like, this is the image.
Yeah, it's okay, like if they were like, well, what do I do to lower my cholesterol? Like, no, it's just high.
You have high cholesterol. Yeah.
You have high cholesterol.
This is the picture of your cholesterol. This is the picture of your knee. And that's it. You carry this around with you from now on.
No, stop eating fat forever. That's what they say, right? Like stop running and stop.
Yeah. No butter. It's the worst. Bacon and butter. But what I'm saying is, look, so if you get that and they don't tell you that you need surgery, then you are not your image, and you're not your imaging. This isn't a psychoanalysis podcast. You are not your ego image, but also whatever, we're getting deep today. You're not your imaging. Okay. If there is something pathological on your image, the doctor would see it and you would know it on the thing and then would do something about it. If there's nothing on your image, then you have to find your limits, which is the test, and then do something about it. So pull your knee to butt. Honestly, we're going to finish with the Cossack squat, but one of the other things for those who need to start a bit more passively is, again, we're going to go back to Bobby's Asian culture, is to sit in a child's pose with your knees folded. And you may only be able to do it for 2 minutes, but when you watch Netflix, and I know you're going to watch Hulu, whatever it might be, there's some great shows on HBO right now, but Billions came back on Showtime. Watch that. Kneel for 2 minutes and see how much load passively you can take in your knees, in your ankles, right? And then stop when it starts to feel funky and the blood flow stops. And then wait 10 minutes and go back and do it again for another 2 minutes. You will be shocked how much better you can get just working on this position. But back to the Cossack squat, because I do believe Bobby is correct. It is kind of infinitely progressible. That's a word. Go see the Marcus Philly video, but just start shifting your weight left to right. One of the problems is when people are in pain, they can't shift. Their body is trying to reorganize, and you need to give it an opportunity to reorganize, okay? And so you shifting your weight back and forth, is shifting your center of gravity back and forth, pushing on one foot and then pushing on the other foot, bending one knee, straightening one knee, bending the other. This alternating method of the body is a thing that happens through your entire body. Your heart beats, you breathe in, you breathe out, you blink your eyes, you're awake, you go to sleep, blood flows, blood stops. This alternating movement is the key, okay? And so I want you guys to try the Cossack squat this week. We'll kind of write this up a little bit more specifically. Start with your feet close and move a little bit further away, and then shift to one side and bend down as much as you can. You can use a little bit of support, like hold on to a door frame or a rack if you're at a gym, so that it can help you shift your weight back. Use a goblet squat. Hold a little weight in front of your chest to offset your weight forward so that you can sit back a little bit further. And then just go as far as you can and go back and go forth and go back and down and forth and down. And then the next day, try it a little bit more. I would say minimum 3 times a week, right? And then let's try it for the next month. And I promise you, really good things will happen. It may be a little bit tough on the first day, but that just shows you how much improvement you can make and you will make. Cossack squat. Mm-hmm. Finish it up.
Yeah. I would say, if anybody does this, record, if you want to record it like day 1 versus day X and send it to us, like, I don't know, whatever product we come out that you want. And if you show something cool, because not to prove that it works, but just because I would just love to see one person's like mind blown or life changed or body feel better. And that's worth it to me. We'll give away whatever we can give you if you want to record yourself. And I think it's cool anyway. It's just the same reason
why our
we
stories.
Yeah, it's why we track. It's why we track weight when we lift weights or whatever, because we can measure this progress. So if you feel so inclined, and let us know, that would be awesome.
Tag us in a post, we'll repost it. Want to see your progress. That is our knee episode. We're going to be posting stuff on knees all week. Thank y'all so much for listening to the Anatomy of Therapy. If you haven't already, I know you guys already have reviewed and rate the podcast. iTunes loves that. It's like candy for iTunes. They just love it. But yeah, thank y'all for listening. Have a great day.
Good luck with Cossacks.
Done.